All right, we'll start off with a little background here. How many hip and knee replacements do you think we do in America every year? It probably surprised you. I didn't put a lot of big numbers, but we do almost 1 million hip and knee replacements now in America every year, and that number's a few years old. We do about 2 knees for every hip, and that's just sort of with the incidence of hip arthritis compared to knee arthritis. We also know that...
So that's a combined number?
Correct. Hip and knee replacement, yep. We also know that hip and knee arthritis, or just arthritis in general, has a tremendous burden on people in general. It's far and away the leading cause of disability in America. It's not diabetes, it's not heart disease, it's not cancer. It's actually arthritis. What is arthritis? A lot of patients will ask that. Again, it's extremely common. Osteoarthritis is the most common type. Osteoarthritis is just wear and tear arthritis. Our joints are lined with a smooth white cartilage. When we talk about osteoarthritis, all I'm referring to is that cartilage wears away. You'll hear me talk about it in the office. I use the analogy of paving a road. If you pave a road, you have a really nice smooth surface. If you come back 5 years later, especially here in DC, there are going to be a lot of potholes in the road. The road's going to look pretty bad. That's actually what the surface of the joint starts to look like with arthritis, wear and tear arthritis. Other types of arthritis, much less commonly, are autoimmune arthritic conditions like rheumatoid arthritis, psoriatic arthritis, spondylus arthritis. Those are a lot less common. We used to see this, a lot of technical. We used to see rheumatoid and autoimmune arthritis a lot more commonly, but the drugs have gotten so good that it often doesn't make it to surgery these days. It makes up less than 2 or 3% of the patients we see now. We'll talk about some different treatment pathways. We always start with non-operative treatment options for arthritic conditions: education, weight loss, exercise, physical therapy, bracing, medications, topical, oral, and then even intra-articular or injections into the joints. We're not here to really talk about non-operative treatment, so we're going to talk mainly about the surgical treatment options for hip and knee arthritis. Arthroscopic debridement, we don't do very commonly. Studies have shown that it's relatively equivocal in whether or not it's going to help someone. Osteotomies are done far less commonly than they used to be. Osteotomies just refer to cutting the bone and realigning the bone, mainly because joint replacement over the last 30 or 40 years has become so good and so consistent that those other treatments just don't have the efficacy. So we'll start out with some basics. What do we do in a hip replacement? A lot of people think that with a hip or knee replacement, it's like a transplant, like we cut out a whole part and just reinsert another piece. In reality, both hip and knee replacement, for the most part, we're resurfacing the bones. The surfaces are worn out, especially with knees, and we're replacing the worn out surface with plastic, metal, and ceramic typically. And I've got a model here that will probably better demonstrate. We can pass this around, you can come look at it later. And this is a model of a hip replacement. What we do on a hip replacement is I make a cut here and I remove the worn out femoral head. Okay, we chuck it in the trash, it's worn out. We take a metal stem, often made out of titanium these days. Most of them have a coating that the body likes, it mimics bone. We wedge that really tight on the inside part of the bone, and your body actually thinks it's bone and grows into the part. Within about a month, your body actually grows onto it and it becomes part of the bone. On the end of that, we snap on a ball. There are different types of balls. Most commonly, we're using pink balls like this, which are ceramic these days, although we still use metal balls occasionally depending on sizes. On the socket side, we take reamers and mill out the remaining cartilage on the inside of the socket, and then we take a hemispherical cup, also with a coating your body likes, and we wedge that really tight on the inside part of the socket. Your body will grow onto this as well within about a month. On the inside part of the socket, we actually will snap in typically a piece of plastic, a plastic liner. And I'll talk in a minute about the different types of liners you can put in there and why we choose one over the other. So again, this is talking about what we do, essentially what I just summarized there with the model. And this gives you an idea of what the progression looks like. You've got a normal appearing joint there with a smooth surface, the arthritic joint becomes rough, like that road with potholes in it, and then we remove a portion of the head and replace it with metal, plastic, and ceramic. These are the bearing surfaces I'm talking about. That was a hotter topic a few years back with hip replacement. And the quick history lesson on that is that in the 70s, 80s, and 90s, the limiting factor in hip and knee replacement was the plastics. Those were the things that would wear out. And that's why patients would be told that you're too young to receive a replacement, or if we're going to replace you, we're going to have to redo it again in 15 years, 10, 15 years. Those statements are probably not true anymore, which is pretty cool. And that's based.
Which you said you're waiting. I'm sorry.
Yeah, hold on that. We'll get to that.
I know which part you were talking about.
We'll go through all of the bearing surfaces in just a second. So, but back in the 80s, when they were seeing problems with the plastics, we started working on alternative bearings. And that's where metal liners came, and that's where ceramic liners came from, and ceramic balls. We were trying to look for a way to not use plastic. Concurrently, they also were trying to figure out what was going on with the plastics and trying to improve those as well. The metal-on-metal replacements had some really good theoretical benefits. They also performed very well in the lab. These are the ones that you're seeing the late-night TV commercials for recalls and class action lawsuits. These, in practice, did not perform very well at all. In fact, they were pretty awful. Almost nobody's using these anymore. Hopefully, no one's using them anymore. Concurrently, we were working on ceramics. Ceramics have the ability or the properties of being very smooth. So they have the lowest wear characteristics of any of the materials we use. The downside is that they're brittle, sort of. I mean, if you had this in your hand, you could hit it with a hammer, it probably wouldn't break. But there is a risk of ceramic fracture where the liner will actually fracture. And there were a couple brands in the mid-2000s that actually squeaked. And when I say squeaked, I mean you could hear it. And so these are not as commonly used. There are also some size limitations with ceramics, especially the socket side, to where we don't typically use this except in our extremely young patients under 25 or 30. I start to consider using a ceramic socket. Ceramic balls, on the other hand, have become more of the standard of care. The wear rate is better, the risk of fracture is minuscule, and we don't run into any of the metal problems with ceramics. So probably 95% of the balls I'm using today are ceramic balls. But getting back to the plastics, in the mid-90s, they made some changes to the plastics, and the modern plastics came out in the late 90s, early 2000s. So we have almost 15 or 20 years data on the new plastics. And amazingly, we're not seeing the problems we were seeing in the 80s and 90s with the wear at this point, 20 years in. And that's why, for the most part, we can say that it's unlikely that people are going to wear these plastics out. Now, we still have to follow people and surveil them, but the materials are that much better. So it's really a game changer for what we do. But those are how we think about bearing surfaces in hip replacement. So hip replacement was actually voted the surgery of the century around the turn of the century because of how profound the pain relief was and the improvement in function. And we're only better at doing it today than we were 17, 18 years ago. Patients will have marked pain relief and tremendous improvements in function across the board if their main problem is hip arthritis. The hotter topic these days has been, how do we do the surgery? How do we get into the hip? And there are different ways. The traditional ways have been the posterior approach coming in from the back, and then the lateral approach coming in from the side. The newer approach has been coming in from the front, or what is called an anterior approach. It's not brand new. It's been popular for 10 to 15 years, so it's been out there, and more surgeons are becoming trained on it, and the equipment has really improved. The benefits of the posterior, so there are pluses and minuses with all of these approaches. The posterior approach has really been the traditional approach. The benefits are it provides excellent exposure. It's a relatively easy approach to perform. The downsides are you split some of the muscle, and the risk of dislocation is the highest among all of the approaches. The lateral approach, the benefit is that the risk of dislocation is much lower. However, you have to remove some important tendons in order to get into the hip, and you repair those. Sometimes people will limp, sometimes permanently after that particular approach. The benefits of the anterior approach kind of combines those. We go through naturally occurring muscle planes, so we're not cutting or splitting muscles, we're going between the muscle planes. We don't violate any of the posterior structures in the back, which is what leads to the higher risk of dislocation. And then an added benefit with the particular technique I use is that patients are on their back during the surgery, and I'll show you this in a minute, so it allows me to use x-ray during the operation. So when I'm putting the parts in, I'm literally looking at the components, so there's no mystery about where they're going. We don't take an x-ray after the surgery and go, woo, that looks great. We actually are looking at it while we're putting it in. So again, traditional approaches, you're typically laying on your side, which makes x-ray very difficult. We kind of went over some of the benefits and downsides. This is a quick video. I wish it was this easy. Let me see if I can get this thing to play. The animation kind of shows you. And then boom, the parts are in. It's how it is in real life, not really. There are different ways to do the anterior approach. The particular technique I use and has become pretty popular uses a special table. It kind of looks like a medieval torture device, but it allows us to manipulate the leg and makes the surgery easier and improves the exposure. So benefits, again, of the anterior approach: less trauma, smaller incisions typically. Most patients will have less pain because we're not splitting or removing muscle. There's going to be less tissue disruption. Studies have clearly shown that you do recover faster. It's not tremendously faster, but a few days, patients are off their walker quicker. They're off their cane quicker. They return to work a little faster. I don't typically give patients restrictions after surgery when I do the surgery from the front, which is, if I was having the surgery, that's what I would be most interested in. I wouldn't want to be thinking about my hip going forward. And then we think we're more accurate with the component position using the x-ray during the surgery, and hopefully all of this leads to a lower dislocation risk. Patients get up right away with the surgery. In fact, in some cases, we're even offering this particular operation as an outpatient, believe it or not, which just shows how far we've come. In the 80s, you would come in a day or two before surgery. You'd have surgery, it would take all day. You'd be in the hospital for 2 weeks. You'd go to rehab for 6 weeks. And now, like tomorrow morning, I've got a case in the morning, and the patient will be home by 1 in the afternoon, which is pretty amazing. Those are for selected patients that meet criteria to qualify for that. But it just shows you, we get patients up right away. You'll be walking, practicing stairs, working on getting dressed, doing normal everyday activities. And I've also incorporated and actually included in this some other technology here. You'll receive instructions when you leave, obviously, with exercises, physical therapy, those kind of things. There's actually an app I've been using recently, which is really awesome, where I've been able to tailor it, and I can interact with patients. They will ask questions through the app. You can communicate with me through it. It has exercises, it has check-in questions. Hopefully we can head off problems before they become problems. It's a way for us the way I think of it, it's like we're virtually rounding on people. Since patients are spending less and less time in the hospital, it's a way for us to keep in touch with patients on the outside. All right, now we're going to shift gears and move on to knee replacement. Again, let's talk about what we do on a knee replacement. And I'll talk about different types of knee replacements. In general, the surgery itself is basically the same whether you're doing it with custom devices, robots, whatever, lasers, whatever's out there. In the end, again, we're resurfacing the joint. We ultimately make cuts along the end of the bone and recap or resurface it with a piece of metal. Same thing on the tibia. We'll make cuts here, remove 1 or 2 ligaments usually in the middle portion of the knee, resurface it with a piece of metal, and then we snap in a piece of plastic in between. We also, in America, usually will resurface the back of the kneecap as well. And again, you can take a look at the parts if you want before you leave. Again, we don't use ceramics typically in knees because they're a little bit more brittle, so it's almost always a metal and a plastic. There are different types of metals we'll use. There are different designs. All the major companies have pretty good knee replacements at this point. There's not a lot of difference between They'll have little bells and whistles here and there. And then what we call off the shelf, and I'll talk a little bit more about that in just a minute. Overall, knee replacement's been a very successful operation. It's excellent at pain relief. Typically will greatly improve people's function. However, for some reason, about 1 in 5 patients, if you ask them, are not satisfied with the knee replacement. Doesn't mean we didn't help them. If you look at their scores objectively, almost everybody benefits tremendously from it. But for whatever reason, they'll tell you they're not satisfied with it. And we don't completely know why. Is it that their range of motion isn't what they need to have, or the quality of the motion, meaning the way the knee moves? The knee is a hinge, but it's not that simple. There's other movements in a normal knee that's not simply front and back. And even the best knee replacements we have don't quite reproduce what God gave us with a normal knee. Is the balance off a little bit? That's how the knee moves. Are we running into sizing problems? Everybody's a little bit different. I don't know if you remember a few years back, they were advertising the gender knee, the female knee. You remember that? It was like fantastic marketing. But what it boiled down to is it gave us more sizes. If I put the female knee in a guy, I never told him he had the female knee. It just meant that size fit his bone better. But it was fantastic marketing, and they sold a lot of knee replacements. Patients were asking for it. And then, are the patient expectations not appropriate? Is the surgeon not laying, the framework for what to really expect from a knee replacement? It's probably multifactorial. It's probably some combination of all of these, or things I haven't even thought of or mentioned. So over the last couple years, there's been one difference or one change in knee replacement, what we refer to as the custom knee replacement. There's one company out there that makes a truly custom knee design, and I'll explain what that means in just a second. But the knee replacement, a custom knee replacement, is really designed to avoid improper fit and hopefully some limitations which are going to lead to more natural motion, less instability, and hopefully less wear of the plastics. There's some issues with terminology when you start talking about knee replacements. When I refer to custom knee replacement, what I'm referring to is this particular company will take a CT scan and they will virtually perform the surgery with a computer. They will use 3D printing technology to build the implant unique to your knee, including the guides and the jigs used to put the parts in, sterilize it all, package it, and ship it to the hospital. No two implants are alike, and they're able to balance the knee through varying the thickness and the plastic and the metal of the implants. Some surgeons will talk about custom knee replacement, but really what they're talking about is custom instrumentation, meaning the jigs, the devices we use to make the cuts are customized to the patient, but the implant is still an off-the-shelf implant. They're still going to the shelf and going, you're a size 3 and a 2 and taking them. It's kind of like shopping for a shoe. You go there and you're a half size. The custom knee replacement is the opposite. They're actually building the shoe to fit your foot, which is interesting technology. And then robotics, we've heard a lot about that recently. Very interesting. There are multiple different platforms out there right now. Essentially what robots do is they make the cuts for us. All the companies that are using the robots still are taking their off-the-shelf implants. They're not customized implants. The robot is probably able to make more accurate cuts. There's less variation. And then some of the technologies are able to help us balance. We're able to get pressure readouts and down to really minute details, which is really interesting technology. Some require CT scans or MRIs beforehand. Some do all of their referencing in the operation. This particular device here does all of it in the surgery. Back to the custom knee replacement. So again, this is unique to the knee. Let's see what I have on this slide. We're able, because the knee is customized, we're also able to remove a little bit less bone than we would with the normal implants. It also facilitates less soft tissue dissection, because what I refer to as balance, that's when we put the parts in. If they don't move perfectly, we actually have to start releasing tissues to help the knee glide normally. Because some of that balance is built into the prosthesis, we're able to dissect less tissue with this particular implant. And then hopefully it's going to translate into better outcomes and a more natural feeling knee. It's way too early at this point to be able to say one implant is better than the other at this point. But it's intriguing enough technology and it's enough of a paradigm shift that I'm very intrigued by it and have been using it for about a year now. Again, the process to go through for a custom knee is we obtain the CT scan. That's really the limiting factor. That gets sent to the company who recreates your knee digitally, builds the implant, sterilizes it, ships it to the hospital, and then it's ready for surgery. It takes about 6 weeks. That's one of the few downsides for them to do all this process. It's actually, they're based in Boston, which they had 3 nor'easters in a row that hurt their supply chain. So it actually put that out a little bit longer a couple weeks back. A couple other things on the horizon. There's something called a bicruciate retaining knee that is potentially making an impact at this point. It's really early on. What that means is most knee replacements, we either remove one or both of the cruciate ligaments in the middle portion of the knee. And this is also a reason that potentially patients are unsatisfied with their knee. There is some what we call proprioception, which is little nerve fibers in those ligaments that provide feedback to your brain subconsciously that tells you where your knee is in space and just corrects things. Ideally, we would be able to design an implant where we get to keep both of those ligaments. Right now, we either, I said, sacrifice one or both of those and substitute them with the plastic and the design of the implant. There's a company, actually I think 2 companies now that have come out with new modern bicruciate retaining knee replacements. This is not a new idea. It's been out for, there were some early designs even in the 70s. Unfortunately, the results have not been very good, and that's why it's not caught on. And the reason is that it's a very technically demanding surgery to be able to do this reproducibly with jigs with the way the anatomy is. Potentially, it has not been combined yet with the robot that I'm aware of, but potentially some of those techniques, custom implants, combining some of these may actually lead to more reproducible techniques and hopefully a more naturally feeling knee. One of the downsides, though, is that most people that have severe arthritis don't have normal ligaments at this point. There's been contractures and things like that, so we're also kind of going to learn a lot about that as well. So the ligaments we're saving aren't exactly normal usually. And that's all I have for you tonight. So I'm going to open it up to questions.